behind time, but we just quickly go to the next activity, which is a panel discussion. And I'd like to invite Henry to join the panel. Helen and Sylvia will sort of moderate the panel and take over chairing the rest of this session. Oops. I don't want to fall off.
Okay, we're going to have to do this quite quickly because of the time, but we wanted to have an opportunity to have a bit more of an open discussion on some of the issues that have come up during the day, and to try and pull some of them together. The way we're going to do this is we've got one main question, and then our panelists are going to respond to some particular issues within that, but then we really want to ask people from the room and also the people who are online to join in with their own particular views on this question. And the question that we're actually posing in this session overall is whether ICCM is one of the vital approaches to achieve high and sustainable coverage for major childhood illnesses. So to kick off this discussion, I'd like to start by asking Helen one question, which is, do you think there are particular settings where ICCM may not be viable?
Okay. Thank you, Sylvia. I think I would think more about the benefit and why we do ICCM in the first place, which is about increasing reach and coverage of effective treatment for particularly childhood illnesses. And looking at it like that, I think we need to see how we can reach the areas where it would have most benefit, and where we can manage what we need to do to change the model to deliver quality services that can be well monitored. And thinking a little bit outside the standard model that we have at the moment, I mean, if we look at our experience from South Sudan, for example, which was very challenging with our model, and we had to close earlier, and you could say that was not viable, but I think that what we in the future, we would need to look at how we adapt the model to be able to deliver, because clearly there's a great need there, and that would be a great example of how we can increase the coverage and the access, and looking at how to strengthen community ownership to sustain the project, peer supervision, etc. And I was also thinking about in Mozambique, for example, the Ministry of Health have a pilot where they're using the private sector distribution systems to get the drugs out there, and it's been quite effective. So I think I was looking at it more in that angle.
Okay, that's great. So there are not many situations where it probably wouldn't be worth even trying. Henry, you want to add something there?
I wanted to add to that submission by further describing effective treatment. Mm-hmm. And by effective treatment, it actually means early identification, and then the time of actually starting the treatment. I mean, if diagnosis can be picked up as early as possible, and then the correct treatment starts within the first 24 hours, that is what saves life. And very often, much as infection actually takes place at the household level, the decision to go to the facility is actually in the hands of either the household head or a mother who has very many competing priorities. And that is where we lose most of the life. So ICCM actually goes a step further to involve the beneficiary in the decision making. And this decision making is actually backed by evidence. And that is why it is very, very important for us to start breaking down ICCM into very clear outputs of healthcare service delivery.
Okay, thanks very much. And while you're discussing, can I ask you, in Uganda, do you think we can achieve as high coverage for these health problems without ICCM as you could have with it? And also, how does the Ministry of Health actually balance competing priorities for investment?
In trying to start the debate around that and the discussion around increasing coverage without ICCM. It's very important for us to look at what has been done so far in Uganda. What have we been able to achieve with the current approaches that we are implementing? There has been a lot of increased investment in making sure that the health facilities actually are more functional. And one of the biggest challenges we are getting, despite the increased investment in equipping and making sure that the facilities have adequate stock, we have a scenario where it is increasingly becoming difficult to attract skilled health workers, especially in the rural setting, facilities that are located in the rural setting. And we have a scenario where a facility has a microscope which is fully functional and has never got out of the box because there is no skilled health worker. We have a scenario like that. We have a scenario where a facility is fully equipped with theater equipment and it has never got a doctor to actually perform the operations. Now, in a scenario like that, it is very important for us to take a step back and say, is there other ways in which we can actually achieve our set targets? And the answers are in what we are seeing currently. We are seeing a scenario where there is increased investment at the household level. Currently, the government is talking about increasing household income. But what are some of the things that actually undermine increased household income? It is increased bouts of diseases. And these are the conditions that we are talking about. ICCM gives us an opportunity, a very rare opportunity, where we can have an opportunity of increasing promotion of prevention activities that we are doing, like the correct use of long-lasting insecticide-treated nets. 2, early identification of the conditions that we are trying to prevent. 3, providing the treatment early. 4, referral in a correct way. So I will get back to your question. It is actually impossible to achieve our targets without improving on coverage of ICCM.
Okay, that's a strong position. Thank you. Okay.
Just to warn you, that was not stage managed.
That's true. Frida, I wanted to ask you a question which to some extent you've already pointed to, but you may have further information on. And it's whether you could tell us if there is any good information on the costs saved at health facility level as a result of introducing ICCM. I know you're going to be getting more of this, but at present, is there information that we can look at on that?
Yeah, we discussed that a little bit before, and this is something that we look at. We haven't done our health facility costing yet, but as was mentioned just now, it's not, I would say community-based care is not really about saving costs at the health facility level. It's a way of providing more human resources that, or make available more human resources that could provide care at in rural areas in Africa, and maybe we will not see a cost saving, but we will see a different focus on the work done at the health facility. So instead of treating the non-serious malaria cases, those that work at the health facility, they can focus on the more serious cases that the community health workers cannot treat, and they can also have the supervisor role for the people that are out in the communities. So their responsibilities will change a little bit, and they can focus on more advanced tasks, and then the community health workers will be this extra resource at the community level, and just overall they will increase coverage.
Thanks very much.
And maybe just to add a scenario that we've seen now a few times when we go out to visit the health facilities in our areas, and this is anecdotal, but we're hoping to document this more systematically. But in the health facilities where which are kind of supervising VHTs, we find that now at the end of the VHT program, when there's much more high uptake of ICCM, barely have any malaria cases in the health facilities anymore. There's very, very few children who are taken to health facilities for treatment. And in fact, we've even seen antimalarials being shipped back to the central level because they're expiring in the health facilities, because the caseload has gone down so dramatically. And what we see as a result is that instead of having all these long queues that we heard about earlier during the malaria season, the facilities used to be full of sick children. What we see now is a lot of elderly who never used to bother to go to the health facilities for their illnesses. We see now these elderly patients coming in. This is something that we've also heard from the health facility staff, that they're seeing a shift in who actually bothers to come for treatment. And it's no longer the sick children, it's the old people.
And by elderly, do you mean over 50?
No comment.
Okay. So I wanted to ask you a question. You were telling us about some of the research that's going on in ICCM. Which research question would you most like to see answered to guide ICCM's future?
I would say that there are 3 areas that I think we really need to focus on. Starting from the lowest level, I think the tools, especially around diagnostics, is something that we really need to investigate further. We know that we have extremes, community health workers who are like the South Sudan, where there's barely any literacy and they can't hold a pen. We need to use tools that are adapted to that context but can still deliver high quality care. And one of the things we have explored is to use beads to calculate respiratory rate or classify respiratory rate instead of just using UNICEF timers. I mean, there are other tools coming out which are more, and I'm talking specifically about pneumonia, because pneumonia is becoming one of the main illnesses in these areas as malaria prevention activities come up. We do see in many of our countries that pneumonia is actually a bigger problem. So we have to really try to improve the pneumonia diagnostics and make sure that we have tools that can be utilized to help community health workers do a proper classification. Luckily, there is some work in that area, especially by the Gates Foundation, who will be looking at testing new tools for pneumonia diagnosis. Other areas, I think, is around the systems and making sure that there is different community health worker packages, ICCM packages for different contexts. And I don't think we should look at one strategy that would fit every context, because it's not going to work. Every system is different. Every country has a different system. So what we need to have is a set of packages that can guide countries. And it goes back to how many community health workers per population, what should be the ideal workload, what should be the incentives for a particular workload. Like, if, for example, in Uganda, where a community health worker on average see 3 children per week, does that require a full-time salary? Or should there be other incentives that can motivate them to continue that work? Whereas in countries where there's a full-time job, what would be the minimal salary that should be paid? So I think it goes back to really looking at deployment and the appropriate ratios, and how do you then incentivize community health worker. And that's something we don't really have much information about, what model fits best where. The third one is around supervision. I think supervision is really the most critical component for sustainability, not only because it ensures that we get quality care as a result and that children get the appropriate treatment, but also as a key motivating factor for the community health workers, because no one wants to work in isolation, regardless of whether they get money or not. No one wants to work completely in isolation. And I think we need to find ways of and do research, health systems research, to see how supervision can be much more, how supervision models can be integrated into the curriculum of health workers, and perhaps be integrated at an earlier stage in health worker training and so on, because supervision skills are low and many health workers don't even have the basic level of supervision, supportive supervision skills. So there's a lot that could be done in that area.
Great. Henry.
Yes, I think it's also vital for us to look at questions that are going to justify investment in ICCM. For example, what is the cost saving at the household level as a result of ICCM. Okay? And I think a study like that will actually give more information that will actually increase or justify corporate social responsibility investment into systems that will help functionalize ICCM. And another question that I can see is that how has ICCM helped in increased participation of the beneficiary? Very often, we make a very big assumption that the household, the beneficiaries at the household level do not want to be part of the decision making on the kind of health service they would want to have. But very often, it is lack of information. And one of the key things about ICCM is that it is providing information at the household level in a simplified way that can help someone to make a decision. For example, if I came to a household and probably there is a problem with the under 5, and after I have dealt with the under 5, there is a question about, you know, a small pain in the breast. And I encourage that person to go and seek health care, right? That is a decision that would have been ignored. But just because I've interfaced, it can actually help in the beneficiaries actually going out to seek for more, for health services. So there are many things that we can actually study that can actually justify investment at the community level. And I think as we go further, the more we want to be more cost effective in the investment in health service delivery, we need to start that discussion of the mechanisms that can help get more information at the household level for them to participate. And I think those are some of the things that we can delve into to make sure that we justify the future of ICCM.
Right. Thank you. So finally on the panel, I'm going to ask James to sort of give an overview of his answer to the whole question on whether ICCM is vital for increasing coverage and sustainability, and then I'm going to find out more from people in the audience what their take-home messages are.
Yeah, I would like to say yes to that question, but what I'd like to paraphrase it within is the context that we should be striving for sustained high coverage. Too often the question is about the sustainability of each channel. And yet, what we need to be achieving is equity, timeliness, and appropriateness of treatment. And that is what we need to sustain. This therefore implies that there are other channels. There's the private sector, there's ICCM, there's health facility-based care. All these channels contribute towards a certain level of coverage. But if any of these countries is to achieve the MDGs, whether in 2015 or beyond, it's about high coverage. High coverage of prevention, in a strategic way, high coverage with treatment as well. And so I'd like to see the global agenda shift away from thinking about the sustainability of each, but rather how each contribute to sustainable high coverage. It's not to say that we should ignore sustainability capacity. Each program should have a level of sustainability that allows it to be resilient to the shocks that have been described. For example, commodities, health worker capacity, quality of care. Those are shocks that can actually undermine. And so, as a global community, I think our focus has been too much on channels, but rather should be on the complementarity of these channels in various contexts. What might be feasible today, 5 years later, might be different. The private sector at the moment is potentially unregulated. The private sector deploys drugs that are fairly of questionable quality and also various prices. And how do we over time change that to make that channel more complementary to what is happening in the public sector? So in my view, I would say yes, it is critical, more so at the present time, and going forward we need to bring on board the private sector.
Great. Okay, I'd like to ask anyone in the audience who would like to either challenge the points that the panelists have made or ask them further questions or just come up with comments, things that you've all wanted to say all day and haven't had a chance.
Thanks, Sylvia. I think I'm not going to challenge anything. Everything they've just said is totally correct, and it's probably such a big it's such a big agenda that it's not just one sector or one organization or one agency that can take care of it. I think in terms of resources, we've got the know-how. We've got the Child Survival Series from 2003. We've got the new one this year after a decade. We know that proven interventions don't cost that much. It's about allocation of existing resources. We don't probably need corporate social responsibility to save children's lives. We need equitable redistribution of resources. For countries like Uganda, where 70% probably of health workers are in Kampala. For countries like Kenya, where 60% of doctors are in Kenyatta Hospital. So it's about reallocation of resources, and ICCM is a strategy that scales up access. I think the thing that we need now is leadership to scale it up in those countries. The resources exist. It's about allocation of resources for child survival within the ministries of health's budgets. It's not the NGOs, it's not the donors who are going to solve the problem. It's the leadership in those countries.
Okay, I think, Eleni, you had a point?
The first comment we've got is from Boy Betty Udom at WHO, who says ICCM is definitely the best approach strategy for delivery of healthcare services for childhood illnesses, and we must all make a conscious effort to sustain it. We're advocating to donors to support this strategy, which will help boost the routine services and scale up strategies such as mass campaigns. So that's one comment. We have another comment saying, I think ICCM may not be viable in communities with conflict where there is no clear leadership or cohesion. I think the basic ICCM principles can be modified to suit these settings, which relates back to Karen's point. And then we have a question for Dr. Katamba asking, the Ministry of Health in Uganda has put a ban on the construction of new health facility 2s, and it is now policy. So how will this affect the referral system from the VHT level to the health facility level, and how have the managers of ICCM planned to cope with this new development?
It's a ban on the
health center 2s.
Oh, okay. Construction of new health center 2s. Now, the structure is such that from what we consider a health center 1 is the village health team, the different members of the village health team. And their work is mainly early identification and correct referral. The health center 2 has capabilities of providing treatment for simple ailments and also doing referral. A health center 3 is able to perform deliveries, the simple deliveries. And a health center 4 has the capability of conducting at least a cesarean section. And a health center 4 actually refers to a hospital, which has a variety of services. And currently, the coverage of health center 2s, when you take into consideration public facilities, the private not-for-profit, and the private, almost all the 112 districts have a very high coverage of health center 2s. Now, the issue is there are resource implications in classifying a facility as a health center 2. And currently, the proportion of the budget that is allocated to health has remained less than 7% of the national budget for the last 5 years, and it's not going to change very much in the next 3 to 5 years projections from now. So right now, the main focus is on consolidation of what we have currently. And rather than put more resources on bringing on more new health center tools, we are putting more resources on functionalizing what we currently have. And that is where ICCM comes in strongly as a complement to the current structure. If we strengthen the community component, then there will be less demand on the health facility-based components, and it will help us to consolidate better, meaning that we shall attract health workers there. We shall also improve them to be able to handle a wider variety of conditions which are not preventable. Okay? And I look at it in terms of a complement rather than a competing priority in this case.
Okay, thank you very much. We're running very short of time now. I think we've got time for one more comment or question from the floor and then a few final wrap-up words from James. Any prudence?
I just wondered if we considered some of the risks associated with providing services in the community in not encouraging families to go to health centres for preventive activities like immunisation, because immunisation is very important in reducing child mortality as well, and that if in the past if children went to the health centre they might have been able to be given their immunisations at the time, and I wonder if there's a risk that if we're providing care in the community that the children then won't go to the health centre to have those preventive activities.
No, I think Henry, because he's emphasized the role of using yes. ICCM as a platform for information.
Yes, that's a very good question. And it's very important for us to understand the context within immunization, within which immunization is provided. There are two areas where immunization is provided. The very first place it's provided is at the facility, right after delivery. But that only caters for a very small proportion of the children who are actually captured into the immunization program. The majority of the children are actually mobilized at the community level. And actually the work of the village health teams is to make sure that on the specified days that are scheduled for immunization, they actually mobilize the mothers and the children to actually go for the scheduled immunization days. Now, this is where ICCM comes in strongly. Why? It allows a VHT to actually get a deeper understanding of the household and actually be in position to advise on many of the opportunities that come along. And it shouldn't be ICCM should not be looked at in isolation of the other interventions. And that's very, very important. Where we have seen very good contact with the households, especially with the village health teams, we have also noted a very high coverage of immunization services and even antenatal care. So it is a very good, what can I call it, opportunity to actually promote other very, very important services. I'll give an example. In some of the areas where the ICCM has taken root, in the 34 districts, we have noted that mothers actually attend, we have a higher proportion of mothers who attend 4 antenatal visits. Now, those are some of the things that actually we are observing above and beyond the objectives of ICCM, meaning that it is a very good opportunity to actually promote other interventions that we have.
Very impressive finding. Thank you very much. I think at this point we just have to pass on to James to give us a few last thoughts as we reach the end of this session.
Okay, with that huge challenge, I shall make an attempt to do this in literally 1 minute. First of all, I'd like to thank those of you who've participated in this. I know Sylvia is going to give closing remarks, but I think on behalf of the teams that have worked on this project, I think it's warm to our hearts that you've come to listen to us and engage with us. And as you can see, we have a lot more work to do. I think what we've demonstrated over these few hours is that ICCM is one channel to achieve high coverage for the diagnosis and treatment of the childhood illnesses. Our data has shown us that it can improve the appropriateness of treatment, the timeliness, and that potentially this can translate into reduction in morbidity and mortality. From the discussion, some of the issues that need to be addressed or potentially clarified is that there are various channels through which diagnosis and treatment can be deployed. And we need to better appreciate the role of the private sector in doing this and how together these channels can complement each other. It's also important to appreciate what else can be deployed through the health system platform that ICCM creates. And I think the issues of newborn care came up. But as we think about all these other interventions we would like to add onto ICCM, the issue of integration is paramount. The question about workload and what impact the opportunity costs of having a community health worker in the community having to do more and more. This is something that needs to be addressed. The issue of commodity security was significantly discussed, and I think Henry made it very clear that this is something that is a threat to ICCM. And he also, I think, pointed out that governments have a key role to play, but that partners have to be involved. The opportunities are the Global Fund, as well as the UN Commission, including some others. This is something that will threaten the fragile gains that ICCM has made. And so as a global community, this is something we need to look at. ICCM contributes to quality of care, and this is something that has been demonstrated today. The use of user-friendly job aids, the fact that diagnostic tools can be brought closer to communities, and the fact that, as highlighted again by Henry, the household with its competing priorities can quickly access a diagnostic, access treatment, and the family go back to continue what they need to do. This is a strength of ICCM, and it's important that this platform is clearly understood, is researched, and potentially the costs in terms of how much it costs, but also what are the returns on investment. Incentives. There were questions about should we pay health workers, can they volunteer? And I think that's something that requires further clarification. The data, however, that we have suggests that community health workers are doing this because they're addressing a need and would like to be part of the solution. And this is what I think the public health community has been looking for, a process from which the bottom can get to the top and demand for services and demand that their rights are met. ICCM provides this platform, and ICCM, in addition, provides an opportunity for information to be brought closer to the home. So in terms of the future, I think, this is again my personal opinion, is that ICCM is fragile, but it is feasible and it's acceptable. I think the models to implement exist. What we should be now looking to is to improve these models, to make them more cost effective, and to make them more applicable to the context. And this is what research can do. We also have to think about the continuum of care and the role that ICCM can play in addressing not only the issues of the under fives, but the information that's required for adults, for immunization, for the elderly to be addressed. The MDGs. Without sustained coverage, we can't achieve the MDGs, specifically MDG 4. And so we need to bring these various channels closer together so that the public and the private sector can complement each other to sustain the health benefits. Thank you.
Great, thank you. So I'm just going to end with 4 sets of thank yous. Well, first of all, I'd like to say a big thank you to the presenters today. There was a lot of work that's gone in to getting to the point where we have something that we felt we were ready to share with other people and get your input. And I think it's been a great opportunity to hear it all presented at once, to look at how we balance our enthusiasm with the actual delivery, with the need for objectivity as to what these results are showing and how to get enough numbers to make our findings robust enough to lead towards decisions. Secondly, I'd very much like to thank the people that we're not seeing at the moment, but the people who've been joining us online. It was really great to have your inputs. I understand there's been about 40 people, not always the same people, but around 40 in each session. So we found that quite a nice way of extending the coverage of these sorts of events and getting more ideas coming in. I'd also very much like to thank those of you who are here. Your insights have been really useful. There are a lot of representatives here of partners who've been doing a huge amount on ICCM, and by getting the information from all our different work together, I think we're really starting to get some very interesting conclusions. I'd like to make a special thanks to Dr. Katamba for coming. I wish we'd had a couple more Ministry of Health representatives, because effectively you have much bigger decisions to make than any of us here, and we hope that we can help with actually at least providing better evidence to make the most of those decisions. But I'm sure this debate will continue. We'll be putting some of the materials and the presentations on our website or sending them out. I'm not quite sure which. Both. So thanks all for a good day. Thank you. Bye.